welcome the whole purpose of today, and I suppose my own personal history. I've been a patient recently as well. It was an interesting experience. I was having a cardiac procedure done. I was in the ward afterwards after having my procedure done, and the other patients were there, and they'd had basically interventions for heart attacks during their heart attack. So they were having quite a revolutionary change in care. So I did a kind of a little focus group with the other patients. I was still a little bit high after my own anaesthetic, I think. And so I think they're beginning to really wonder who the hell this guy was who was in the bed. But what I tried to explain to them was, which was an interesting thing, I was very struck that they very much took for granted the fact that they were having a heart attack, they were shipped into the hospital, they had a stent put in, they had absolutely no muscle damage whatsoever, and they were not going to go into heart failure in the future. Whereas historically, obviously, they would have come in and all the reverse of those kind of things would have happened. So I do think while the media coverage of our health service is universally, well, not universally, but largely negative, I suppose, I do believe that we have made some progress. And when you ask patients about their experience when they get into it, it's not always bad at all. So let's see if I can, which one do you think which was forward, right? Oh, well, that's pretty obvious, actually. So my role, historically, I suppose, I trained as a GP, qualified as a GP, went to work in Nicaragua in Central America, where I suppose I really learned about the power of community in transforming health. Nicaragua is always a very poor country, a country where really the basics were not provided for people. And working with communities, we managed to mobilize some resources, their own human resources mainly, to bring sanitation, clean water into neighbourhoods that had none whatsoever. So I think, I certainly learned something from there that I carry with me. And then when I went to work in Newcastle upon Tyne in England, I initially worked not as a doctor, but I worked as a community worker. I decided the only way to make sense of my experience in Newcastle was to work in the West End of Newcastle, work with local community groups, and try to ensure that the health agenda was democratised to a degree in Newcastle. One of the things that was striking in Newcastle, I remember Raj Bhopal was the Director of Public Health there, a very famous public health guy, and I was at a public meeting where he presented massive research he'd done on diabetes and heart disease in Newcastle. And I asked him, I said, it's really great research and congratulations, but to what extent were the communities that he'd studied aware of the results? And he had to admit that they were unaware of the results, and the results were alarming. So that led to a collaboration where we mobilised data into the community. Data, for example, that showed that Tudor Hart's inverse care law was alive and well in the NHS in Newcastle, where you could put a map of Newcastle on up, and it would show the different neighbourhoods. We'd give you the rates of heart disease in the different neighbourhoods. You could then put up a map of access to heart disease treatments in Newcastle, and there was no match in the map. They were inverse. So the areas with the lowest rates of heart disease had the highest rates of access to treatment. And that's in a completely state-funded public health service. So inequalities are not unique to our own health system, but we do have very significant ones in our own health system as well. So I suppose that's led me on when I came back to Ireland to, when I worked at the Department of Health, I headed up at the HSE an initiative to develop a service user involvement strategy. And we had a long debate about what term to use, and I'm sure you will have views on that, and we need to continue to evolve the language. As people said, patients is not all encompassing, service users is a little bit depersonalizing maybe, people maybe is the best thing to call people, because that's what we all are, we're all people in the end of the day. But we had I'd say about a 6-hour debate on that one, so that was interesting. So where are we at the moment, or what's going on? I mean, I think we all know this. I would say, having worked and continuing to work in Mountjoy Street in the inner city in Dublin, we're about 300 metres from the Mater Hospital, so I could throw a stone, if I was good at throwing, I could throw a stone probably from the practice into the grounds of the hospital, hopefully not hit any patient. But I couldn't get a patient in there very easily though. My patients are all GMS patients, and the obstacles to access to specialist opinion at the moment are really massive, and the waiting lists have been well publicised, and we really have to address that, because I don't think we can have a quality service that we can't get into. It's not, it could be great quality for the people who are in there. It's not great quality if I can't get in there. It's no use to me at all. So I'm very, I suppose, exercised by that, and it's not a problem that's going to be resolved easily, but it is one that we need to really care about. Obviously, the financial cutbacks have, and this is a red letter day obviously for Greece. I just met a Greek man this morning. I was chatting to him about it, and I suppose, we weren't far off what's happening to Greece at the moment, and we maybe have come out of it somewhat differently. But we've gone through a really awful time. I mean, the health services have taken a hammering financially, morale-wise. So many people are doing two people's jobs now. There was a moratorium. People left. People were encouraged to leave. We lost some of our best people. They were encouraged to retire, which I thought was really a shame. And then you have people doing two jobs. So that's kind of a hard environment in which to work in. We're really struggling around recruitment and retention. We struggle to recruit all grades of staff, but strangely enough, these days we're struggling to recruit consultants as well. And I'm not picking out consultants for any special mention, other than for two reasons. One, that we never used to struggle to recruit them. There used to be 30 applicants for every post. Now you're lucky to get one or two applicants. And the reason is that they've been singled out for particular attention, I think, in pay policy, where they've absorbed the normal pay cuts, but they've also had a 30% additional pay cut, which was like a message to the profession, I think. A message that they listened to, and the response is, we're not coming back to work here. So I think that's kind of a poor outcome for whatever the message was. So I don't agree with it, and I've kind of been speaking against it, and we continue to document the impact of our inability to compete worldwide for clinical leadership. So I think we need to address that, because otherwise we're not going to have a quality health service. I think in terms of, like, I would always be asked when we look at our monthly performance report, what do you think of it from a quality perspective? I have to say, very often my response is unhelpful, insofar as I would say not a lot, because it's not measuring a lot in terms of quality of care. It's not measuring a lot in terms of outcomes. It's very hard to get new measures measured. There's not a lot of measurement going on. The system is creaking from the burden of information provision, and yet we still have a performance report that, if you look at it, which you should do, it doesn't, although it's probably a bit boring, but it's worth a look. I would say you would agree that it doesn't really tell us a picture of what's really important to you and to me. So we're working on that. Media and morale, I've been asked historically, and I'm thankful to say that won't be an ongoing situation, to front up for the health services when things have gone wrong. When a specific service has failed, I've been kind of asked to speak to the media about why it failed and what we're doing about it. That was probably a mistake in some ways for an organisation, where it can lead, I guess, to the services themselves not really assuming full responsibility for their own failures, because if somebody else has to go out and take the heat, then maybe that's slightly falling a little bit short on accountability. But one thing I did learn from that was that we are under attack. Anytime I went into the media, there was no question of really listening to me on the side of the media. It was really a lot of interruptions, a lot of preconceptions, a lot of assumptions that we didn't necessarily really care, a lot of assumptions that we were entirely financially driven and didn't really care about patients. And actually an awful lot of conversations that happened around that time were very much focused on finances, and that did lead, I'm sure, to decisions that did compromise patient care. So hopefully we're moving out of that environment now. But that has an impact on morale as well. When every time you listen to the radio or watch the television or open the paper and it's something to do with health, it's a negative story. So I think that's something that has an impact on all of how we feel about things. In the HSE, we have new divisions. We have, and the word division is a loaded term, I suppose. We have a division of mental health, primary care, social care, health and well-being, operational divisions, all of these, and obviously acute hospitals. And while that's really excellent in terms of providing kind of national leadership in areas that have maybe traditionally been somewhat neglected, so I really welcome that in that regard. But clearly it leads to a major challenge around integration of services. And integration is a challenge for services worldwide. I'd say it's probably the single biggest challenge, and it's one that we haven't sorted here. I'm sure you would all agree from your own experiences. But we need to. And the other thing, I suppose, given my role has kind of evolved from firefighting and dealing with complex adverse events all the time to really trying to improve things, I think overall the health service is probably relatively comfortable in firefighting mode, because we do a lot of it. And in a way, while it's uncomfortable personally at times and you can be attacked, What you do is fairly laid out. We have policies and what you do when something bad happens. You implement the policy, you investigate, you apply learning, and you apologise hopefully early on, and then you hopefully move on and improve things. Whereas the whole process, practice and care improvement, which is what I'm trying to focus on, is called the soft side, but I call it the hard side. Certainly the difficult side anyway. It's a lot harder people give out to us about that we don't learn as a health service. I think if you look at health services all across the world, learning, making sure that the 100,000 staff all absorb the lessons of something that happened in one part of the service is a challenge, and it's not one that's easily addressed. And finally, I would say, as a public health doctor as well, if we're not acutely aware of the trends within our society, both in terms of an aging population, albeit from a very young base, but one that will really have a massive impact on demand. Chronic disease trends that are certainly adverse and will lead to significant rises in chronic diseases and cancer. And the previously mentioned technology demands. I mean, we've been asked to make decisions on medications recently that it would break your heart not to agree to them, but it would break your budget to agree to them, and we've largely agreed to them. I don't think we've really ended up hardly rejecting any drugs. We've given some recommendations to the Minister that are somewhat nuanced, recommending that the impact of funding this is at least put against a fixed budget where something else will have to give. That debate hasn't really been had with society though, and we roll on. So, what is improving quality? Well, there's various definitions around what improving quality is, and I won't dwell too much on this because it may be boring, but it is important. First of all, I believe it's the job of everybody. It's the job of everybody here in this room. It's the job of all of us as managers. It's the job of every clinician, every carer, every family member and every patient. We can work together, and if we do genuinely succeed in harnessing collective efforts, I do believe we will end up improving quality in a systematic way. But it is something that with everybody applied to it, we should be able to achieve better patient population outcomes, supported and valued staff, and I'll come back to that in a minute, and a better care and better patient and service user experience. It's interesting, what would you measure in terms of quality? Well, what I would measure is the staff likelihood to recommend the service that they work in, and the patient or service user's likelihood to recommend it. They're probably the two most important quality measures that there are, and we've started to measure both of them. And this is a study from an organisation called Press Ganey in the States. They do international surveys, 55,000 hospitals. It's the biggest sample size of its type in the world. And if you correlate an employee who thinks the service is good with whether a patient is likely to think it's good as well, it's a direct line relationship. So all the evidence shows that if we look after our staff better, and we don't look after them particularly well at the moment, if we look after them better, they will care better, patients will have a better experience, it will improve outcomes, it will reduce mortality, and it will reduce healthcare associated infections amongst other hard patient outcomes. And there's an absolutely clear evidence base for that. So I'm working very closely with the HR division in the HSE to develop something that we're calling a people strategy that I think hopefully will change our relationship with our staff, because we did a staff survey that showed that staff do not feel valued, and we need to address that. My own division is going to really focus on things such as what we're calling at the moment person-centred care. Again, maybe out of today or other discussions, the language will continue to evolve, but that's essentially a commitment which I'll come back to describe what we mean by that. Supporting staff and improving quality. I believe if we were able to mobilise the efforts of frontline staff to really feel valued, to really go the extra yard, which by and large they do anyway, but that kind of discretionary effort would make a greater contribution to healthcare than any negotiated agreement with any set of representative bodies. We are very, very committed to measuring more relevant things that are important to patients and service users, and improving on the back of that. And we have a particular programme to address issues of governance. In other words, that the newly emerging structures such as the hospital groups and the community healthcare organisations will genuinely put at their core quality and safety, and not slip back into budgetary management mode at the expense of other considerations. So examples of some things that we've done: we've worked initially in the Dublin Northeast using a methodology adapted from the US called a collaborative series methodology. It essentially is a mechanism for large-scale change, testing it, measuring it, showing it works, getting buy-in, and applying it. And across 22 settings in the Dublin North East, they achieved a 73% reduction in pressure ulcers using this methodology, which is a big partnership, not terribly costly, not terribly time costly, four events over an 8-month period, mentoring and support in the middle, a proven method for improvement applied, and a massive patient result, I think, as a result. So, we can do it. So what we're going to do as a result of that is there's a lot of pressure now on us to start to implement collaboratives and everything, because all of a sudden collaboratives work and we're always seeking some magic bullet. How can we change this? How can we change that? Collaboratives, that's the new thing. So let's do a collaborative on everything. So there's a demand to do about 20 collaboratives. The system would simply tell us to get lost. So what we're going to do is we're going to embed the collaborative pressure ulcer reduction across the northeast. We're going to spread it down to the Midlands and spread it nationally. We're going to do it nationally. We're not going to do any of the collaboratives at all in the meantime. We are pursuing what we call a strategic approach or a framework for quality for health services. Not terribly different from what any other jurisdictions come up with, I would say. We've certainly looked at what everybody else, how they describe things. But we do believe, and we'll be developing a paper that will become publicly available, that really tries to explain what this actually means and how we're going to make some sense of it. How we're going to make sure that people take it seriously and that it becomes our way of looking at things. So a framework for quality is based on primarily, I think, very importantly, leadership. So leadership demonstrating that we want to improve and we're not just satisfied with the status quo. Supporting person-centred care, as I've already said, is a priority for our division, but it has to be a priority for everybody. The whole concept of safety is obviously central. We must try to reduce harm. We're doing, in collaboration with Graham, a major study on adverse event levels within our system, which we should know the results of as the year progresses, and hopefully we come out not too much higher than other international studies on adverse event incident. But we know anyway ourselves that adverse events occur. We'd like them to stop occurring. It's very hard to eradicate them, but we need to minimise harm. We need to support staff to improve care. That means a different relationship with staff than we currently have, and that needs to come from the bottom up and the top down and meet in the middle. We need to learn and measure better, and we need to get our governance right. And all of this hopefully will lead to, if you like, an evolved culture. So, what about partnership? Partnership with the public and service users. Well, from the point of view of my own directors, we have been championing a number of initiatives. One is a national patient forum, which some of you will be involved in, and is an open forum, so more can be involved in it. We have a Patients for Patient Safety Network, which is part of a WHO global initiative built around the experience, really, initially of Margaret Murphy, whom many of you may have heard speak, a very inspirational individual who's turned an absolutely crushing tragedy for herself into a momentum and a movement for change that is built around the patient experience, the family experience of when things go wrong and what we need to learn from that. So we'll be working with a group of people who are in that space to try and make sure that they have the opportunity to influence what we do and what others do in relation to the issues that they identify as being important. We've been doing listening exercises, particularly with older patient groups, and we will be championing a person-centred care initiative, which I'll come back to in a minute. And as an organisation, the HSE is a co-signatory to the Service User Involvement Strategy. So there are various things that have arisen out of that. There are patient for and acute services, and I'll come back to some of the issues around these initiatives in a minute. Some of the primary care teams have engaged the local community. Mental health services have a pretty evolved model of engaging service users, and we're hopefully in response to the tragic experience of seeing the Orsa Tractor programme and knowing what went on there, developing an intellectual disability services, a new model of partnership with families and service users there as well. So what are the issues in participation? I suppose I've worked around service user and patient and public and community participation for probably about 30 years. And there are many issues, and I'm sure you recognise most of these issues as you've participated in various fora, participated in various groups. You might be the patient rep on a strategy group or whatever. And there are things that can happen that are somewhat far less of what we seek to achieve when we promote participation. Tokenism is the thing that people will often talk about. That's really being at the table but not being listened to. It's an extraordinary experience. I've experienced it myself. You're at something, because when I worked in Newcastle, I worked really as an advocate from outside of the system, so I've kind of seen it, if you like, from that side as well. I've been at a meeting where a major strategy is being discussed, and I've said, well, what about this? Wouldn't this be a good way of doing things? They say, great idea, thanks very much. And then I notice it doesn't ever get written down on the whiteboard or on the flip chart. So I'd raise it again and say, I think you forgot to write it down. It doesn't get written down the second time either. It can be a really amazing experience, and it can be pretty deliberate. So tokenism happens. Co-option is another risk, obviously. If I'm kind of isolated, I'm on this big high-powered group and they're all talking about molecular biology or complex aspects of service reconfiguration, and I'm there kind of nodding and I'm kind of starting to get to know the lingo, and I kind of become one of them. So I cease to be one of me. And that's a danger. I lose my own agenda and I get kind of co-opted. So that's something that we have to mind out for and support people to ensure that doesn't really happen. Now, the main question really I always ask is whose agenda is in fact being addressed here and being advanced. If I'm participating in something, and that's as an advocate, that's the question I ask. I ask it of myself. And if I feel I'm not actually having any impact, then I'm best off out of it, because things are not changing. And that's a question that we will ask as we evaluate the aforementioned structures that I described to you earlier. So we need to support people, we need to give them information, they need to be on a level playing field. I think sometimes it's helpful for patient representatives and service user representatives to come from some kind of constituency, some kind of a larger collective that can be like a sounding board, a place to check back to, gives people additional oomph when they're there and saying, well, our people don't agree with you, it's not just me, our constituency is of a different view. So if we can help kind of patient groups and service users kind of collectivise a bit around their participation, I think it strengthens that participation. The other danger is cliques, and I've worked with a lot of groups that become very hostile to new members because they're kind of comfortable with each other. Maybe it's been a bit stressful forming and getting used to each other, and then when they get used to each other, they don't really want to shake that all up again and have some new people come in and make a mess of things. So again, I think that's something we need to be wary of and make sure that our participative processes are really open and flexible and evolve and allow people to come in and come out. And then ultimately and fundamentally, I think people suffer a lack of feedback. If you're not getting feedback on your participation, then again, you must demand it. So I think the bottom line question for me is, what has changed for the better as a result of my participation? And that's the only question that really matters in a way. So in terms of person-centred care, I suppose we're trying to promote, and we're obviously very affected by some of the adverse events that have occurred, but that people will be treated with dignity, respect, compassion, kindness. It's a funny thing to talk about in a way, but if any of you, who've been in hospital or in care recently, as I have been, a little bit of kindness goes a hell of a long way. Somebody just touching your arm or showing some understanding that you're an individual, that you're not just one of a group of people with the same condition. I think that really makes a huge difference. It certainly did to me. We need our care to be coordinated as patients, as service users. Otherwise, it's not person-centred; it's service-centred. It needs to be personalised. We need to understand that every person is an individual, and we're going to try and pilot or test. We're stopping using the term pilot. We're going to try and test a number of things in this space to see if people can get used to them, cotton on to them, and then we can spread them around, getting people to understand prompts that everyone is an individual. They have different aspirations and hopes, different thoughts, different desires, different needs. Service users as active participants, that's just obviously a central part of person-centred care and obviously a central part of today's discussion. And also that we build services on people's strengths, not always focusing on people's weaknesses or deficiencies or disabilities, we build on people's capacities. So part of what we hope to do in this space is going to be a central focus of our work plan from here on in. We've been promoting a program called Open Disclosure, which you may have hopefully heard of. We've done massive amount of training in that space, trying to get people to respond differently when things go wrong, because effectively, historically, people have become very defensive, frightened, and have gone into a hole very often when things have gone wrong. This completely compounds the harm that's been done. And everybody says the first conversation that happens after an adverse event sets the tone for everything that happens thereafter. So we need to get better at that, and we're training people to try and do that. We've been developing disability access guidelines as another arm of what we do. to try and make sure that people can get into our services in the first place, and that they understand people's capacities and not just their disabilities. And we plan, to see if we can get a more flexible family presence policy, understanding the key role of the family in healing, and an initiative that we've engaged with from Canada called What Matters Most to Me. So it's a kind of like a storyboard at the patient's service user's bedside or wherever they are. So if I'm going around as a clinician, I get a prompt that this person supports Manchester United. I try not to hold that against them, try and get past that. Or they support Kilkenny and I might support Tipperary. But at the same time, I think the purpose of that, I think, is pretty clear. I think you'll agree, and certainly something that we're going to trial here as well. We're going to see if it works. We're going to see if people can cotton onto it and use it properly. There are obviously different forms of participation. We can be involved in managing our own care as a patient. Hopefully we're moving in that direction. Patients are certainly becoming far more informed and clear about what they want and need. But again, that will be unequally distributed across our society, I would say, and I would see that in the practice that I'm in. You can also obviously get involved in service developments that are specific to your own condition, so you can help improve services for a particular condition or a particular set of conditions. And also people can become more strategically involved, and hopefully we're going to see more and more of that. So in conclusion, and I hope I haven't gone on too long, I believe that everyone should expect to be able to participate in their care if they're able to themselves and if they want to. I think the service user voice is going to be crucial in developing appropriate and effective services. I think the participation must be real, and there's a real danger that the participation is not real, so we have to really evaluate participative models and processes to make sure that it is real. And I think that feedback is essential and clear outcomes must be achieved. You can follow us on Twitter. We're reasonably active on Twitter. We haven't got into trouble on it yet, bound to in the future. So thank you very much.